Welcome to the Explainer. So today we're doing something a little different. I want you to step directly into the shoes of an infectious disease specialist with me. We're going to decode some of the most rapid, life-threatening medical mysteries that exist in modern medicine. Yep, we're talking about opportunistic fungal infections.
To really understand the stakes we're dealing with on the front lines, let's talk about a terrifying number, close to 100%. That is the near total mortality rate of untreated invasive pneumocystis jirovecii pneumonia, or PJP. When these specific infections take hold, we're not just treating a bad cough, right? We are quite literally racing against a ticking clock. Every single hour we delay our diagnostic reasoning, the patient's odds drop dramatically.
Okay, let's dive into this by understanding our enemy. Opportunistic pathogens aren't some exotic bugs found only in remote jungles. They're ubiquitous. They are in the soil, in decaying matter, literally in the air we breathe every single day. For a healthy person, completely harmless. But they're opportunistic. They basically wait in the wings, and they only trigger a full-blown medical emergency when a patient's immune system drops its guard. Whether that's from HIV, organ transplant immunosuppressants, or profound diabetes, that's when they strike.
Section 1. Patient X and the Pulmonary Case Study.
Now imagine this clinical presentation: profound neutropenia, presenting with fever, worsening dyspnea, and pleuritic chest pain. As an ID specialist, when I see patient X presenting with these exact symptoms, my mental alarm bells immediately start ringing. Profound neutropenia means their body has virtually no neutrophil white blood cells to fight off invaders. The worsening dyspnea, or shortness of breath, combined with pleuritic chest pain, that sharp stabbing pain when taking a breath, tells me whatever is in their lungs is incredibly aggressive, and it's destroying tissue fast.
Section 2. The suspects and our differential diagnosis.
So we have to quickly narrow down our main culprits based on the patient's underlying host defects and symptoms. It's kind of like a matching game. If our patient has had an organ transplant and is coughing up blood, invasive aspergillosis jumps right to the top of the list. What if they have poorly controlled diabetes with ketoacidosis, or profound neutropenia and we suspect massive tissue necrosis? Then pulmonary mucormycosis is our prime suspect. On the flip side, if a patient has advanced HIV or is on high-dose steroids and presents with a dry cough leading to sudden respiratory failure, we pivot our thinking entirely toward PJP. The host-specific weakness tells us exactly which invader just walked through the door.
Section 3. Clue analysis and distinct imaging markers.
Here is where things get really fascinating. We have a direct contrast between two distinct radiographic clues. They sound super similar, but they tell wildly different stories. First, the halo sign. This is a solid nodule surrounded by a hazy ring of ground glass opacity. That haze, it's actually a zone of hemorrhage around the fungus, and it strongly suggests invasive aspergillosis. But compare that to the reversed halo sign. Here, the center is the hazy ground glass, surrounded by a dense ring of consolidation. If we see that in a hematology patient, our heart rates absolutely spike, because that is highly suggestive of pulmonary mucormycosis, a true drop-everything fungal emergency.
We're also constantly watching for something called the air crescent sign. This is such a cool marker. We typically see this literal crescent of air form around a large nodule on the CT scan when the patient's neutrophil count is finally recovering. It's actually a visible sign that the immune cells are returning to the battlefield, fighting back and physically separating dead tissue from healthy lung in cases of invasive aspergillosis.
But what if we don't see those distinct nodules or halos at all? If we instead see this diffuse, hazy ground glass pattern spread bilaterally across both lungs, literally looking like someone wiped a cloudy film over the entire chest scan, well, our suspicion immediately pivots. This isn't a localized mold. This is the classic textbook presentation of pneumocystis jirovecii.
Section 4. Microscopic detective work. Stains and branching.
Moving to the lab, a direct tissue examination under the microscope forces us to look at the literal geometry of the fungi. Mucorales fungi are recognized by their broad, ribbon-like non-septate hypha. That just means they don't have internal crosswalls, and importantly, they branch at wide, 90-degree right angles. Aspergillus, however, looks very different. It has those internal walls, called septa, and it branches at regular, acute 45-degree angles. Honestly, when you're an ID specialist, knowing your angles is literally the difference between prescribing the right life-saving drug or losing the patient entirely.
But hey, remember PJP, our ground glass suspect? It famously won't grow in routine lab cultures at all. No way.
Instead, we have to rely on specific stains of the lung fluid. The Grotkott's methenamine silver, or GMS stain, is just incredible for this. It turns the PJP cysts dark against the background, making them look exactly like tiny crushed ping pong balls. Alternatively, we use calcifluor white, which uses fluorescence to reveal glowing kidney bean-shaped cysts. It's microscopically beautiful, but incredibly deadly.
And here is a surprising, absolutely critical warning for the lab. We must completely avoid standard tissue grinding if we even suspect mucormycosis. Ironically, this incredibly deadly tissue-destroying fungus is actually super fragile under a microscope. If the lab grinds the tissue to culture it, they'll completely destroy those broad, non-septate 90-degree hyphae. That leads to a false negative result while the patient continues to crash. We have to be incredibly careful with our specimens.
Aside from microscopy, our biomarker blood and fluid assays act as a final rapid check. Galactomannan is a cell wall component that's highly specific for Aspergillus. Beta-D-glucan and spikes in the LDH enzyme heavily support a diagnosis of PJP. But there's a huge catch here. The Mucorales fungi that cause mucormycosis will sneakily test negative on those standard fungal tests. So a negative biomarker test absolutely does not mean the patient is safe if the clinical signs point to mucor.
Section 5. Diagnosis and Rapid Response. The Action Plan.
Once we've nailed down the diagnosis, our clinical response has to be immediate. This multidisciplinary three-step protocol is absolutely life-saving. Step 1. Start the specific targeted antifungal immediately. Step 2. Aggressive surgical debridement. This is especially crucial for mucormycosis. We literally have to surgically remove the dead, necrotic tissue because the fungus causes angioinvasion. Basically, it destroys the blood vessels, meaning our IV drugs can't even reach the site of the infection. And step 3, rapid reversal of predisposing factors. We have to fix the high blood sugar, or reverse the neutropenia, or honestly, the drugs just won't work on their own. We also have to be incredibly precise with our first-line weapons. If it's mucormycosis, we bring out the big guns. High-dose liposomal amphotericin B. If it's invasive aspergillosis, voriconazole is our absolute gold standard. But look at PJP. We don't even use standard antifungals for it. Because P. jirogeci lacks a cell membrane component called ergosterol, normal antifungals literally just bounce right off of it. Instead, we use an antibacterial combo called TMP-SMX. It's a perfect example of why we must match the exact right weapon to the right pathogen's biology.
The diagnostic puzzle of opportunistic mycoses is for sure one of the most intense and high-stakes arenas in medicine. We are constantly learning to read the subtle clues of geometry, imaging, and biology just to save lives. But I'll leave you with this final thought to mull over. As our medical capabilities advance and we develop more incredible, life-saving immunosuppressive treatments for cancers and organ transplants, we're simultaneously creating a much larger population of vulnerable patients. So how will we continue to outsmart the ancient, ubiquitous fungi that are constantly just waiting in the wings? Thanks for stepping into the clinic with me today on this explainer. Keep learning and stay curious.